Hi, my name is Ben Atkinson, and welcome to Season 2 of the Functional Health Podcast. I'm trained in both biomedical science and nutrition, and I firmly believe that a holistic and functional approach to health is fundamental to our well-being. I interview some of the leading voices in nutrition and lifestyle medicine, from practitioners to professors and everyone in between. With this podcast, I will share with you their stories, their expertise, and their advice, shedding light on the industry from each of their perspectives and providing you with simple tips and tricks to help improve your health from today. This week, I'm delighted to be speaking with Dr. Rob Lawson. Rob is a medical doctor and conventionally trained GP and is the chairman and co-founder of the British Society of Lifestyle Medicine. Rob is also the founder of a charity offering lifestyle classes and advice to patients with chronic health conditions. Today, we dive into the fundamentals of lifestyle medicine. So, without further ado, Rob, welcome to the show.
Well, thank you very much, Ben. It's always nice to chat to fellow members.
So Rob, for those who aren't aware, can you please explain what lifestyle medicine is?
I would describe it more as an approach rather than a discipline or specialty in itself. That in itself is a controversial viewpoint. However, in terms of definition, I suppose it's about the application of environmental, behavioral, medical, and motivational principles to preventing, managing, and reversing, hopefully, lifestyle-related disease. That includes self-care and self-management. I mean, that's one way to look at it. I tried to explain this on one occasion at a public meeting, and someone says, "Well, what does that actually mean?" And so I said, "Well, this is a bit of a cliched analogy which has been applied to other areas, but I tend to use the dripping tap analogy.
Yes.
Water dripping into a basin and all the water spilling up onto the floor, and all of us in the National Health Service in particular going around and mopping up all the water, and people have forgotten to turn the tap off, and lifestyle medicine is about turning the tap off, and it's dealing with upstream problems. And I think that analogy seemed to meet their requirements. They understood that much more easily, I think.
Yeah, I think that's an excellent analogy and a great way of explaining it. Now, you've seemed to be arguably ahead of the research in this field, and you've practiced these lifestyle medicine principles since 1991. When did you become aware of the benefits of incorporating lifestyle medicine into clinical practice?
Well, I think that the benefit, that's a hard one to answer actually in terms of a timeline, but in terms of lifestyle as medicine, that didn't occur to me until I was clearly in my years as a student. But I grew up abroad, as it happens, but I was sent back to my home country, Scotland, for my education from the age of 10. Mm-hmm. And I spent a lot of time with my grandparents, and my grandparents, one or two little sayings sort of stuck with me. One of them was, a stitch in time saves 9. Prevention better than cure.
Yes.
And that kind of intuitively felt right. And so why would I not take that into my professional career? And slightly to my surprise, during my formative years at university, I don't think prevention ever came up. It was never a subject that certainly I was aware I was being taught. So it wasn't easy to learn at the onset. And the only opportunity, if you like, of being able to put it into practice was when I became a principal in general practice. So,
yes.
So that was, and that takes us back to when I started in general practice, really. So it was when I started in general practice that I became more aware of how it could be applied in practice.
Right, okay. And what were the first kind of applications of that? Did you advocate more dietary approaches, or was it exercise-based? How did it start?
Well, it started in an area where I felt I was in slightly firmer ground, and that was through physical activity.
Yes.
It started principally because of a need locally where I live that people who had heart attacks, and in those days people had heart attacks seemingly quite regularly and often, the old idea of you just go to bed for 10 days was beginning to be challenged. And I think there was enough evidence around the world that rehabilitation after a heart attack was actually quite important. And so I recognized fairly early on that my patients simply didn't want to either engage, and certainly didn't want to engage with a program that was over 20 miles away in Edinburgh. I actually practice in East Lothian. So it was that understanding that people didn't want to make that journey and perhaps didn't quite engage with the process involved in rehabilitating after a heart attack. So it was that the other critical thing, I think, was yes, exercise is good, especially to rehabilitate cardiovascular-wise. The next important thing really was the supportive mechanisms that arose out of providing that service. I knew I couldn't really sustain it within my practice. I tried on a one-to-one and quickly recognized that that wasn't really going to work very well. And eventually, the only way I could develop that was to form this charity that you mentioned right at the start. And that really was the start of it all, if you like, of lifestyle as medicine before it became known as lifestyle medicine.
Fantastic. Thank you very much for explaining that. So 28 years ago, diet wasn't even really taken too seriously as a clinical tool, never mind other lifestyle habits. How accepting were patients and I suppose your colleagues of these new principles when you began to use them?
Well, I think that the only principle that they could see I was using was evidence-based. I mean, I think that it was accepted that cardiac rehabilitation in particular, which is how it all started out,
yes,
was accepted generally. However, I think it largely still applies in large areas, that the physical activity aspect of it was seen as a lifestyle choice and was not part of what doctors and GPs should be involved with. And that, to a large extent, meant that I was an outlier, and the only way I could proceed was to do this in my own time outside of the practice.
Yes.
The practice did give me an hour a week of practice time to spend on it, but obviously almost all the time was in my own time. So the short answer to your question is that it wasn't widely accepted and still isn't widely accepted enough, that the benefits of physical activity in that supportive environment which I was creating for patients was much more important than almost anything else that we did in our surgery.
Right. Is this in part the idea that it's not very widely accepted what inspired you to start the British Society of Lifestyle Medicine?
It seemed a natural next step. You know, I think that I reached the end of my career in general practice. The last few years I found really difficult. I could see what lifestyle was doing to people, just not just as individuals, but collectively at community level and beyond. And I suppose I became even more frustrated, but not only because of my colleagues' attitude to it, but because of patient attitudes. That I was shaken, I would say, by, on one occasion, a patient had been to Thailand to have the sort of total body screening that they do over there for a pittance. And they came back with 3 diseases, or so he said,
Right.
and 4 different drugs. So I had to untangle that, and in the process, of course, I mean, I knew he smoked, he drank to excess, he was greatly overweight, he never exercised, and when trying to begin to get round to addressing these subjects, he went and complained to my partners that I wasn't taking him seriously, and that all I seemed to be caring about was his lifestyle. So clearly that was a failure on my part to understand that I wasn't engaging with him, but it also underlined, I suppose, the gap between conventional medicine and lifestyle medicine as I was trying to practice it. That the conventional end would focus on specific metrics, whereas lifestyle medicine was trying to deal with the upstream causes. So that link, if you like, between public health and conventional medicine was exposed at that point by a singular patient. And that made me realize that, well, when I retired, I wanted to practice this style of lifestyle as medicine. And the only way I could do it was privately. So I actually put all my pension money into a center, which I had built effectively in my own patch. And it had about 29 different health providers. It had a cafe where you had healthy meals. It had a shop that sold healthy food, and had a gym and so on and so forth. So it was a wonderful way to work.
That sounds fantastic. A really integrated centre.
It was, and I loved it, but unfortunately my money ran out, so I had to close it. And the realization then, of course, that, well, actually in our healthcare system, something like that has to be approached rather differently. And I was clearly idealistic. I'm not a businessman, and it didn't really work out. But in terms of delivering lifestyle medicine, it was fantastic. So the question then was, well, okay, this hasn't worked. How can we make it work in our healthcare system? And that's when effectively in my head that this notion of getting the British Society of Lifestyle Medicine set up, collecting all the people around the country who were increasingly understanding the value of it, to create this community, to allow an education platform to develop, and then the influence to develop out of that. And that was the start of it. And I had one or two colleagues who clearly got it, and together we said, well, let's just do it. It started from there. If I can go back just a little bit, during my time of setting up the centre, I struck up a friendship with Professor Gary Egger, who's from Sydney. And he's, I would say, one of the fathers in a way of lifestyle medicine. Mm-hmm. And he had been very encouraging about the centre and was talking about how in Australia they wanted to do this. And when I began to feed back to him and think, look, this isn't going to work, he said, oh, we should maybe thinking of doing something different. And he told me that he'd been in America at a conference, and as he was passing a doorway, he stopped and listened to one of the presenters. And that presenter was somebody called Dr. Well, he's not a doctor, a medical doctor, Lawson. Mm-hmm. And he was talking about this thing called shared medical appointments. Now, right. We were talking about this, and then it suddenly struck me that I've been actually participating. I had been running shared medical appointments in this Rest of Life program, or the cardiac and pulmonary and so on rehab program that I had running. Mm-hmm. And I had never thought to transfer that into my daily practice. So we began to develop this idea of shared medical appointments. And it struck me that was the way in for lifestyle medicine to get into our healthcare arena. We needed to present it in this format in the National Health Service. GPs, as a GP, I could not spend that hour I was spending with patients in my centre. I couldn't do that in normal general practice. So how could we get the benefit of that time translocated, if you like, into general practice? And the shared medical appointment seemed to be the perfect procedure within which we could do that. And that's why I then set up this thing called the Shared Medical Appointments UK. And that gathered together people who could see that there had to be a different way of delivering healthcare in this country. And that was a precursor to the British Society of Lifestyle Medicine. That was an intermediate step, if you like, before I set up the British Society of Lifestyle Medicine as a charity. I don't know if that's a bit rambling, no. But I hope it makes a kind of sense.
No, I think it does. And just for clarification, those shared medical appointments, is that getting a group of patients together which have a similar medical condition and then teaching them about lifestyle medicine principles and how to implement them?
It can be anything you want it to be, really. It's a bit of a chameleon, but effectively, yes. It's about people with chronic conditions in particular. That's where most of the research is. So people have, I hate to label people with conditions. I've always had an aversion to that.
Okay.
We are people first and foremost, we're people that happen to have maybe one or two conditions. And that's the clue, really, is that we very rarely just have one. And if we understand where the chronic conditions are arising from, we realize that actually a lot of us have a lot in common, irrespective of the particular label of disease that we happen to have attached to us.
Yes.
So this seems to be a way of getting into dealing with broad areas of lifestyle medicine which affect almost any condition, well, certainly the chronic conditions, and 80% are reversible or avoidable ones.
Mm-hmm.
It gives an opportunity to direct people into lifestyle behavioral changes which will improve their condition. And this seems to me to be an ideal way of doctors and healthcare professionals to deliver on that.
Yes. And you said the term there, healthcare professionals. Does that mean that the lifestyle medicine can be advocated for by dietitians, other allied health professionals? Or is it primarily for GPs?
No. I absolutely think it's part of the wider healthcare approach, and GPs clearly are very important in all of this because, on average, we see our patients 4 or 5 times every year. So people have a culture of going to the GP, so they're very, very important.
Yes.
But within the GP team, you cannot actually apply lifestyle medicine principles as an individual. It has to be a team approach. So as a GP, I need people with skill sets that I don't have to help the patient forward. And I certainly foresee, and the reason why BSLM is developing its diploma, which is open to healthcare professionals from degree level up, we're also developing a lifestyle medicine health certificate, a coaching certificate for others. So those that are degreed, if you could put it that way.
Yes.
And that includes personal trainers and others who have an interest in people's health. So I'm rather anxious to get this across the board, not only into primary care, but into secondary care as well. Simply that we have a means of transmitting to patients that there are actually choices that they can make. And it's not just a question of take this pill and everything will be fine.
Yep, and I think that's a fantastic outlook. Like if everyone's, I suppose, singing from the same hymn sheet, if you will, then this message is only going to get across quicker, that you can prevent diseases through these lifestyle medicine principles. Out of interest, why should people get certified? What is this lifestyle medicine certification giving people?
Well, I think that it's the most important thing is that I may have called myself a lifestyle medicine practitioner or whatever for 30 years. In my head, that's what I thought I was, and I know from speaking to others that they think so too. But it's not until you begin to stop and spend some time on this that you realize there's a lot to it, and there's much more to it than people realize. So in order to try and get a benchmark, to achieve, if you like, a standard that can be applied globally, it seemed entirely appropriate to go with the Lifestyle Medicine Diploma Certificate that the International Board of Lifestyle Medicine has brought into effect as of last year.
Yes.
So I think that if we want to get that benchmark, we want to set a standard, we have to have that qualification, I think, to offer. So that if someone comes to see me, at least they know that I have reached a certain standard. Okay, we're still feeling our way in that respect, but it seems to me to be a higher standard than I thought when I started out. And that's actually, to me, that's very reassuring. And I already feel a sort of an affinity with my fellow diplomates in that we've been through the same stuff. We know that we're kind of talking the same language and that we're singing from that same song sheet in a way which was just guesswork before then.
One thing I would like to get your opinion on is, from your experience, do you think prescribing lifestyle medicine can help in all chronic conditions, or is there certain ones which you'd say it can't?
I would say that there's almost I can't think of very much that can't be helped through making changes in lifestyle and approach. I know that they say that 80% of chronic diseases are lifestyle related, but if you think about it, a lot of even autoimmune diseases, there has been an epigenetic switch that's been shown at has been thrown at some point. And so what were the conditions that were in place that allowed that to happen? I can't help but feel intuitively that if you optimize the environment, not just the external environment, but the internal environment, that maybe that epigenetic switch will go back to default and the disease will go. So I like to think that it has a global impact on health, not just on long-term diseases or lifestyle-related diseases. However, I think lifestyle medicine as a discipline is fixated quite correctly, I think, on the reversible lifestyle-related diseases. So I don't want to step too much out of line there.
No, I completely understand that. But I guess, I suppose stress management is what I'm thinking of there. I can't see anyone who won't benefit from just reducing their stress levels through whether it be a mindfulness approach or meditation, or even a more active form of stress reduction like yoga, qigong, tai chi, something like that.
I think you're absolutely right. I think that there's no doubt that the drivers of modern disease include the presence of cortisol coursing around our system. So
yes.
Stress reduction is important. I think that the driver of disease, of chronic disease, I'm completely sold on Otto Mischligil's work in the late 90s, where he showed that metabolic inflammation was a trigger for chronic inflammatory disease. That we have clear paths to identify in acute diseases where the causative agent is, if you like, and that's the actual bug, the microbe or bug or bacteria or virus or whatever. We know that is the cause, if I can put it that way, of acute infections. So what is the equivalent for long-term and chronic diseases and lifestyle-related diseases? Well, I think that what I brought on fairly quickly was Otto Mischligil's work and Gary Egger's application of this word called anthropogen, that he equates the sort of causative agent in acute infections being a virus or bacteria or whatever, an infectious agent. The equivalent in chronic conditions is this thing called an anthropogen, which is a driver of metabolic inflammation. So if you look at the drivers of metabolic inflammation, then stress clearly is very important and one that has to be addressed. You're absolutely right.
To put this into context for people, when treating mildly ill patients, maybe they're just borderline hypertensive, in the current system, can you use a trial period of complete lifestyle change before prescribing a patient with a blood pressure lowering drug in this instance?
To be honest, I think it's something that every health professional should be doing. To a large extent, it's a question of almost giving permission to people to do it, to feel liberated to do this, that it's okay to do this. Yeah. Exactly. I think that we're so driven by guidelines that people are treating them like tram lines, and I think that's not really appropriate in the clinical situation anymore. And more people are understanding this, and that's which is wonderful. And I think that this notion that you head straight for a pill has to change, and this is part of what we're trying to achieve, I think, through the British Society of Lifestyle Medicine. As far as someone with hypertension, for example, is concerned, or mild hypertension, first of all, I have trouble with understanding the measurement of it. That if we measure blood pressure, cuff blood pressure at any given moment, it will be quite different 15 minutes later, or even a minute later, or half an hour later.
Yes.
So just coming to that diagnostic label in itself is problematic for me. So I think that that helps me to start that discussion and to start the conversation with the patient about ways in which, if they are concerned about their blood pressure, how we might be able to reduce it. And that conversation starts at that moment. And certainly a prescription pad is certainly nowhere near the desk at that particular moment.
And I guess part of me, the reason for me asking that question is purely because I don't think many patients or potential patients are aware that this is even an option. Maybe they go to a GP who isn't trained in lifestyle medicine, but don't know that there is, I hate to use the word alternative, but another avenue where you can go to someone who is trained in lifestyle medicine and get another approach based on lifestyle and not always pharmaceuticals. I think it's extremely empowering for people to know.
Yes, indeed. And the more people, and I think that in this digital age and internet age, people are becoming more aware than they ever were before. I've never been naive about this. I think that I'm perfectly aware that patients who, in my conventional role as a GP, people were coming to see me, they were bound to have been going to other practitioners. I think that it would have been silly to expect them not to. And as the internet opened up, then I think the nature of the transaction, if you like, of the consultation began to shift. And I think that people perhaps have been quite slow to recognize that largely GPs in particular, I feel, have become or should become much more architects of choice for people. That in the past it was fairly didactic, and there was a doctor as the senior partner in anything that was going on. Now we have to accept, well, what is your knowledge about the condition that you suffer? What are your worries? What matters to you? Mm-hmm. And then let's work with that. And that means that as doctors, we have to be much more aware of what the options actually are. And I think that that's where I hope British Society of Lifestyle Medicine will begin to help people come to terms with options that they can be advising, knowing that it's mainstream and that it will make a difference.
Yes, I think you've touched on something, again, really important, that kind of holistic view of a patient's well-being as well. Not just their symptom or their illness or condition or whatever you'd like to call it, but that they are a person.
Absolutely, yes. I think that an understanding that there are things going on in their lives which are driving whatsoever is going wrong in their lives, and that they have the capacity to change it, or we have the capacity to change it together in partnership.
Yes, I think that's a great way of looking at it. One thing which has come up quite a lot, Rob, recently is that we've seen a rise in depression and mental health conditions. Unfortunately, more people are willing to talk about their struggles with mental health than ever. I know exercise seems to have a profound beneficial effect on mental health when performed properly and at an adequate intensity and duration. Have you found in clinical practice that other interventions or lifestyle medicine interventions can be useful in these instances?
Well, I think that this actually, to some extent, is not something that has been dealt with terribly well in general practice. I think that as soon as a sort of mental health issue is discovered, you either reach for the prescription pad or you refer on to somebody else. And the somebody else is usually involves a 6-month wait or longer. Yes. For counselling. So I think getting an understanding of again starting this conversation, of what is driving this change perhaps in mental health, and getting an understanding of what's causing it or maybe associated with it with the patient, and getting the patient to hopefully come up with some light bulb moments themselves to get an idea of why they might be the way they are, and what then the options were to change that. So I think that if we can shift the conversation away from the objective signs, if you like, to potential causes, we can make a difference. And I can't at the moment see how that can be dealt with primarily with a GP in 10 minutes. I think that's not easy. So I think that the acceptance that our mental health and our physical health are completely intertwined. If we accept that, then within our primary care, immediately within our primary care environment, we need to have the capacity to signpost fairly quickly into an area where the individual will benefit, whether it's from being in a yoga class or Tai Chi, or joining a counseling group, or getting CBT or ACT, or seeing a clinical psychologist for some reason or another, dealing with post-traumatic stress disorder.
Yes.
We need to have that team, if you like, into which we can plug tenuously. I think that the way in which we've approached mental health up until now has been a huge frustration. There's absolutely no point in missing that opportunity of actually making a real difference to somebody's health, mental health, if you then send them out the door knowing that they won't be seen for another 6 months. I mean, that clearly is it's not on, really, is it? So we have to be able to tackle that. And lifestyle medicine principles and understanding the sort of drivers and the causes and associations, at least to, again, come back to this notion of starting the conversation. And as a lifestyle medicine practitioner, knowing to whom to signpost that individual,
yes,
as a colleague, to make a quick input and begin to bring change to that person's life.
I couldn't agree more. I mean, the thing with mental health conditions in general, it doesn't matter which one you are looking at. They're multifaceted and they're caused by multiple different problems. And therefore, the likelihood is they'll need an integrated approach to help manage or overcome these issues in the patient.
Absolutely, yes.
Yeah.
And I think that it's true to say, I can only speak about my own experience, but I think in terms of psychiatric illness or mental health, the trend is to go straight to prescribing drugs, and I think that often more than one drug, and that seems to me a sort of almost an admission of defeat, and I think that that needs to be challenged. I'd like to see a systematic approach to mental health, which is available within every primary care facility, and that team, an integrated approach, clearly is hugely instrumental in achieving that. So yes, I would agree with you that it's an area where we need to be spending much more time on, and that as a primary healthcare physician, we don't have the time, so let's use the assets locally in our community, which can make the difference.
I mean, there are integrative models out there which are funded by the NHS. Dr. Vinita Patel, I spoke to recently, and she works as a paediatrician in a team with a family therapist, I think it's a personal trainer, and I think it's a psychologist, and they work together with normally low-income families in the 98th percentile of obesity rates within London, and they work together with that family over a year to help reduce their obesity and completely change their lives. And I think this approach, if possible, I know the capacity of the NHS is unfortunately diminishing, but these kind of approaches in a mental health scenario, I could only see a huge benefit there when tackling these conditions.
There's no reason why. I think that we can't, within the NHS, have a labour-intensive approach. I mean, the capacity within the NHS is limited, and this is one reason why we've got the #OneChange campaign going, to reduce the burden, if you like, of chronic disease, and specifically on the National Health Service. But in terms of mental health, there is no reason why, in the context of group consultations, as we now call them in England, you can't bring that integrated approach into play. As in this approach, with a one-to-one clinical encounter in the presence of 12 to 14 other people, you also have a facilitator, somebody who's running the group. But you have invited guests or invited important people, and why not have a psychotherapist there? Why not have a psychologist there? Why not have a physical activity instructor? Why not have a pharmacist, and so on and so forth?
Yes.
You have that capacity within that way of delivering healthcare in a way which is doable. It's not, as I said, it's not labour intensive, and to that extent, a lot of the benefit comes from the patients themselves. It's between, it's a sort of the peer of impact that has greatest impact. So as a health professional, sadly, we may not have as much impact as we think we do. Put into that environment of a shared medical point, a group consultation, suddenly the realization that the power lies in the patient and the patient's friends and colleagues and other patients in the room. So I think that in terms of mental health, there's absolutely no reason at all why that approach wouldn't work very well, and at the same time integrate into external community assets in the way that you've just described.
So in lifestyle medicine in general, more research is coming into how stress reduction can help numerous different ailments, how exercise can be beneficial for cardiometabolic risk, depression, etc., as well as nutrition. Nutrition is constantly evolving. How do you see medicine evolving, I suppose healthcare evolving, as more research and more acceptance is happening in this area?
Well, if you've got half an hour, I'll start. Some years ago, I was asked, in fact, by the Royal College of GP locally to write a piece called The Next 20 Years, and I called it The Rise of the Patient, and came up with 10 things beginning with C that needed to be put into place. I don't think it'd be sensible to go through it all, but I think that...
Is that available to everyone, that article?
Well, I mean, I can send it to you. It went down like a lead balloon, I think, generally.
But if you like, I can share that with the listeners. That would be no problem at all in the show notes.
Well, it was just my opinion, and I'm willing to share it because it answers that particular question. There's no doubt that it requires a change in approach and a change in thinking. And one of the items was cradle to coffin care. We have to, as a society, try to understand, well, what is it we want the NHS to provide or society to provide in terms of healthcare? At what point do we go back to Bevan's choices of whether he went for a sickness service or a prevention service? The landscape health-wise has changed substantially, and so we need to change how we deliver healthcare. One of the things that struck me was Estonia, that they have an electronic health record which they brought in, I think, in about 2008. And 90%, as I understand it, 90% of their country have health cards now, and 50% or more are using them online. And this gives a sort of real-time access to health records, which can be utilized to individualize, if you like, healthcare advice. So I think, again, thinking of the future, this seemed to me to be a very sensible way and not that expensive. I mean, I think I worked out it's going to cost £7 a head or something. It's a very inexpensive way to begin to introduce this notion of self-managing care, of being interested in one's care to a population at large. So that is clearly important. The pharmacogenomics is an interesting one. This acceptance that drugs in one size fits all doesn't make sense, really. Intuitively, it doesn't make sense, but that is kind of this blunderbuss management that we have at the moment. It's never felt right. If there's going to be a development in that area of personalized medicine, I can see that that's a good thing to be involved with. I think that, as I said in my piece, that there's a warning has to come with that. And if you've read Peter Gutsch's book, Deadly Medicines and Organized Crime, How Big Pharma Has Corrupted Healthcare, you don't really want to give the pharmaceutical industry free rein. But nonetheless, I think it is part of the future. Mm-hmm. And then, of course, lifestyle medicine never wasn't part of the future. It's only now beginning to rear its head sufficiently that people are recognizing that what we were doing before maybe wasn't having the effect we thought it was. And we should go back to the future and learn the principles of lifestyle medicine all over again, just in the way that Hippocrates wanted us to put medicine into practice. and hopefully then make a difference to the long-term care of our country.
How important is the integration of healthcare professionals as it pertains to lifestyle medicine?
Well, again, I would probably go upstream thinking about medicine as a whole, but
Yes.
I think that I wouldn't use the word integration of healthcare professionals. I'd use the sort of pragmatic term. I think the collaboration between healthcare professionals.
Okay.
I think that absolutely has to be fostered. I think that what should be integrated is the healthcare for the patient. So I think that if we are collaborating in order to integrate the healthcare and get proper care to patients, then that is absolutely very much the right direction in which we should be traveling. So I think that it is important, yes. I would love to see the distinction between primary care and secondary care and tertiary care and third sector care rubbed away completely. I think it's very artificial. It becomes a barrier for the patient. And if we can apply a more systems-based approach to health, all of that will become unnecessary. But again, that's kind of revolutionary. And the way things work in this country, it's one step at a time. And often it's a question of let's shift the deck chairs around the Titanic rather than let's think freshly about where we're heading in the 21st century.
That is a great way of putting it. Now, finally, can you provide the listeners with 3 actionable steps to help improve their health and well-being from today?
Well, again, that's an interesting one. I'm sure people will have their views. I would say the first thing is to stop and smell the flowers. You've heard that saying.
Yes.
Or stop and smell the coffee or whatever. It's really just to reflect upon where you are, where your health is. What are your health goals? And I think that's the first thing I would suggest. Then, of course, and you'll not be surprised to hear me say this, that maybe you could make #1 change at a time towards achieving those goals. I think that we have to make changes. We have to take more responsibility ourselves. I think that's easy for people like me to say, but for people that need it the most, perhaps it's not easy to make those changes. And we have to create an environment that allows that to happen in their particular environment. So that's number 2, is make one small change at a time. And finally, the third one I would say is that once that new change has become a habit, then to go back to the first bit and stop and smell the flowers again and do a little bit, reflect a bit more. Well, where have I got to? How long along the path have I got? And what more do I need to do to make a difference to myself? And I think it's that broad view, I think, that people need to, it's an attitude, if you like. Mm-hmm. It's an approach that I think needs to be looked at, rather than the advice like take more exercise or eat more vegetables or don't stress as much. These are kind of useless sayings, really. It has to come from, lifestyle medicine is about behavioral change. It's about moving from extrinsic motivation into intrinsic motivation. And that's where really the struggle is, to go from that extrinsic motivation into the intrinsic motivation. Learning how to do that as a healthcare professional, and then and trying to impart that to patients and so on and so forth, I think is critical to the success of lifestyle medicine.
Thank you so much for sharing that with us, Rob. I'm sad to say I'm going to bring this recording to a close, but I wanted to thank you so much for coming on the show. I really do appreciate your time.
Ben, it's been a pleasure, and thank you very much for asking me, and I hope in there somewhere there's some sense.
I think there certainly is.
Thank you for listening to the Functional Health Podcast. You can find links to everything that we talked about today in the show notes. If you have a second, please consider leaving a 5-star rating on iTunes. It really does make a huge difference and helps get this valuable information out and reach more people. Don't forget to subscribe so you can stay up to date and know whenever I release a new episode. You can connect with us on Instagram, Facebook, or our website, and all questions are welcome. As always, thanks to Josh Aurelia for the editing and Alan Harper for his support.